Okay, good evening, everybody. Sorry I couldn't be there, and I hope this projects and this records well. My name is Dr. Rani Bhatia. I'm one of the pediatric immunologists, allergists at the John Hunter Hospital, and a long history of association with population health, and work together with population health in the Hunter, New England area to address adverse events post-immunization and help assist these families revaccinate their children. So with the next 30 minutes or so, I hope to talk you through some of the common adverse events that you might see when you are vaccinating these children, and I'll also talk you through a couple of case presentations on how we would deal with that when we get such a referral. Okay. So, what exactly is an adverse event following immunization, also what we call an AFI, so AEFI? Well, any untoward medical occurrence that follows immunization is an AFI. Now, this adverse event may be an unfavorable or an unintended sign. It could also be an abnormal lab finding, it could be an abnormal symptom or abnormal disease. And this doesn't necessarily mean that you've had an allergic reaction to the vaccine. So allergic reactions to immunization form a subset of an adverse event following immunization. So what then is an allergic reaction to a vaccine? Well, here the immune system has reacted adversely to administration of a vaccine, and that is an allergic reaction. So your immune system here is involved, and that's causing that allergic reaction. So as I said, a subset of an adverse event. And types of allergic reactions can be of two main types. One is your immediate one, which is what causes the most concern to families as well as care providers, which is anaphylaxis. And definitely if you've had anaphylaxis, you need a assessment prior to your next immunization because it can occur again. It can be delayed where it is non-IgE mediated, and in here there is some overlaps between whether you actually had an allergic reaction to a constitutional vaccine or whether it was just an adverse event post-immunization. And it can occur hours to days after vaccine administration. And some examples of that could be a fever, could be a localized swelling, you could have worsening of eczema, you might get urticarial rash, you might get joint pains. Now, this is not an exhaustive list, but these are some examples of symptoms that can happen. So this type of reactions neither increases your risk of anaphylaxis nor is a contraindication for subsequent dose of vaccine, but because of the concern that it may raise to care providers as well as to families, these are the ones that could be referred on again for further assessment. So what is exactly the estimate of a true allergic reaction? Well, it's quite rare. It's 1 in 50,000 doses for TPT and 1 in 500,000 to 1 in a million doses for most other vaccines. So if you look at from a number perspective, it's not all that common. But if you then look at the denominator, which is the large number of doses that we do administer, it does make it a relatively common problem. So your allergic reaction could occur to a number of vaccine components. Now that could be the infectious agent itself, it could be the preservative, it could be the stabilizer, it could be the residual media present in the vaccine, it could be the egg protein, it could be gelatin, it could be yeast, and it could be a variety of other additives that are present in the vaccine. So of course your most serious AFI is anaphylaxis. But often you can also get a vasovagal episode soon before or after vaccination, and that can also lead to serious consequences. Now, vasovagal episodes is more classically defined in adults and adolescents post-immunization, but generally children and infants rarely faint. So sudden loss of consciousness post-immunization in young children should be presumed as anaphylaxis to be treated. I guess retrospectively later on, when you kind of break things down a little bit, you might be able to make an assessment that, well, you really didn't have anaphylaxis and maybe had a vasovagal response. But in that moment, I think it would be reasonable to assume if there's a sudden loss of consciousness that it's anaphylaxis and administered adrenaline. So how could you retrospectively look back and say, well, was it anaphylaxis or vasovagal episode? Because it's the most common adverse event you're going to see in your clinics. Well, vasovagal response is often immediate, within minutes or during the time when you're administering the vaccine. Anaphylaxis can also occur immediately, usually within 15 minutes, but can occur a few hours after vaccine administration. Now, in a vasovagal episode, the breathing is going to be shallow and not labored, whereas in anaphylaxis, you're going to see sign of respiratory distress and upper airway swelling, so you're going to hear a stridor or wheeze, you're going to hear a cough. When you then put the heart rate monitor on, bradycardia is what you're going to see in a vasovagal episode, whereas tachycardia will see in anaphylaxis. So just remember, after you give adrenaline and then you put the heart monitor on, you're always going to see tachycardia because adrenaline will induce tachycardia. But prior to giving adrenaline, if you're seeing bradycardia, it's probably a vasovagal response. It's hard to take a blood pressure in little babies, but if you did manage to put the monitor on, hypertension is going to be quite transient in a vasovagal episode and usually will come better as soon as you sit up. Whereas in anaphylaxis, the hypertension is a very late sign and it's sustained. It is not going to get better until you administer some form of treatment, right? And then loss of consciousness in vasovagal episodes usually improves over a period of time. You stimulate and they kind of bounce back. Whereas in anaphylaxis, usually a late sign and suggests a dire prognosis. Also, when you look at the skin with a vasovagal episode, you're going to see generalized pallor, whereas with anaphylaxis, you're going to see redness, you're going to see erythema. Nausea, vomiting, and diarrhea will be seen in both conditions. Patients with anaphylaxis, especially older patients, will identify the sense of anxiety and impending doom with anaphylaxis, not necessarily seen with vasovagal episode. So as I said, treatment is always going to be adrenaline. It is life-saving and must be used. If unsure whether it's vasovagal anaphylaxis, I would often say use adrenaline. I think it is the narrative that follows after the child has recovered that is more important here. So I think it's really important that you communicate with the family at all times and explain why you give adrenaline. Many times it might be, well, I was just being cautious, I don't know what happened. It could be vasovagal, it could be anaphylaxis. I just felt in the moment I need to give adrenaline, the child's recovered. And so you're leaving it open that this may not have been anaphylaxis and that will need to be determined down the road. So you're not closing the door for future immunization. I don't think it's very helpful to say, well, your next reaction could be much more severe. I don't think it's useful to say, well, you may need testing, because they may not need testing, right? I think you're going to have to control the narrative to say, well, this is what happened, this is what I did to help your child recover. I don't know, your child probably needs further assessment, for which we're going to put in an adverse event report and talk to Pop Health and get the child assessed in a specialized clinic. And I think that initial conversation is what the families often remember. I think that's really important, that you put the ground rules that and leaving things open for future immunization. I think it's very, very important that we reassure and support. So what are the various vaccine constituents that we can investigate for IgE-mediated allergic reaction? Well, one of the things is gelatin, and it is present in your MMR vaccine, in varicella and Japanese encephalitis, and in influenza vaccine. And so if a patient came to you saying, well, I'm allergic to gelatin, this history is really not important for having an essential for having an allergic reaction, but if they did report that, and there's a documented allergic reaction, then you might need to send them for further assessment before they have their vaccine. I think egg protein is reported as a constituent in influenza and MMR vaccine, but the amount is really, really extremely small. The only significant amount of egg protein is present in yellow fever vaccine, and hence MMR, influenza, etc. are not contraindicated in children with egg allergy and should be administered in the community. Of course, for a specific family, if they are hesitant because of the child's egg allergy, again, please do consider referring the patient to us. But really, from our perspective, the amount of egg protein present in an MMR, MMRV, or influenza vaccine is extremely small. And even if you have had a severe allergic reaction to egg protein, it can be safely administered. Now, I have heard this, and it's been brought up to me a few times, and therefore I put this in, is casein. It has been anecdotally reported as a potential cause of anaphylaxis after TPT vaccine, and that is because trace amount of casein has occasionally been demonstrated in TPT preparation. However, a vast majority of children with severe cosmetic allergy will tolerate this vaccine, and hence there is no contraindication for a child with cosmetic allergy to not receive the TPT vaccine. The preservatives such as thiamethyl, aluminium, phenoxyethanol do not cause immediate reactions, but they can cause delayed reactions, and often with kids with severe eczema or those who have contact dermatitis, you might get a little bit of inflammatory response at the site of immunization. And of course, we all know that aluminium, which is an excipient and adjuvant present in a few vaccines, can cause persistent nodules at the injection site. The vaccines do contain some antibiotics, which are stabilizers, so neomycin, polymyxin B, streptomycin. So again, these are not common antibiotics that we see in children, but definitely applicable for adolescent and adult patients. So if they've had an allergic reaction, documented allergic reaction to any of these antibiotics, they might need evaluation. And then, of course, with latex allergic patients, we want to use vaccines without a latex stopper. Yeast, and this is something that comes up with the adolescent patients when they're getting the HPV vaccine, that they've had an allergic reaction, or presumably an allergic reaction to yeast, and so they might come to us, and often we would run skin prick test to yeast, demonstrate that they do not have an allergic reaction to yeast, and then administer the HPV. And I have had one patient with a known allergic reaction to yeast who has then safely gone on to have the HPV vaccine without any issues. Now, local reactions can also occur, and these are again fall within the APHE umbrella, and these are usually mild and last for 1 to 2 days. We've talked about the injection site nodules, and a very common one that we hear about is a skin rash 4 to 12 days after vaccination, and often seen in the context of the live vaccine, so varicella and MMR. And again, these are immunogenic, and really almost family needs is reassurance. Febrile convulsions is also rare but do occur after MMR, and MMRV vaccine has been known to occur with Bexsero as well, and previously has been known to occur with co-administration of your trivalent influenza. Such reports haven't been seen with the quadrivalent influenza, but can also occur when you co-administer with Prevnar. We see brachial neuritis, so that's inflammatory inflammation of the brachial nerve, causing pain at the site of administration of the tetanus vaccine. And of course, intussusception has been seen with oral rotavirus vaccine. Commonly, what we get referred about is a hypertonic hypertensive episode, which often gets confused with anaphylaxis, gets confused as a vasovagal response, and sometimes it can be extremely hard to differentiate. But really, an HHE event is a sudden onset of pallor, cyanosis, muscle hypotonia, and reduced responsiveness after vaccination. And here, the difference between vasovagal responses and HHE is that the HHE event can occur up to 48 hours after immunizations and does resolve spontaneously, but it does scare the families. And then one serious adverse event that we see is Guillain-Barré syndrome after influenza vaccine. It's not all that common, but can occur, and in those patients, definitely influenza vaccines contraindicated in future years. This is something that we get questioned about often, and there's no causal link with immunization and SIDS, autism, multiple sclerosis, inflammatory bowel disease, diabetes, and asthma. So how do you reduce the likelihood of adverse events in immunization? I think what we can do and what's under our control is always be prepared. So use your pre-vaccination checklist, correct injection procedures, have some knowledge about adverse events of each vaccine, and also provide them with written information Um, Often you might come across a situation where a family suspects vaccine allergies and will refuse future immunization. And in my experience, come across two groups. So one is a patient who has had a possible reaction to prior vaccine, and here you kind of looking back and thinking, well, was it immediate? Is there other vaccines that you've reacted to, and will you need additional doses of this vaccine or other vaccine similar constituents? And then you have that other group who has a known allergy and worried about an allergic reaction with some vaccines because of its constituents. I often find that in such a situation, when they come for consultation, they've been given a lot of information by other families, but other care providers, but the reason they are in my clinic is because they want to seek more information. So in a way, they've kind of given me consent to address their concerns. But I often still will ask that question after I have heard the story. So my advice often is to maintain the trust and keep your consultation brief. You don't want to bombard them with a lot of information. And really, you are the neutral person, right? We are not the enforcers. The enforcers, the government is controlling their tax benefits and their central impairment payments, etc. Our role is to be neutral, to acknowledge their concern, provide them with our experience and advice and knowledge, and allow them to make that decision. So keeping consultation brief, I think, is really important. Important to listen to and acknowledge their concerns. I think in your head you might say, well, does sound like an allergy to me, but I think for them it's an allergy or an adverse event. So really you want to acknowledge that, yes, it must have been quite scary for you, and yes, this might be what had happened, but let's move on from there, right? Also is, I find giving them a modified and alternative approach, that, hey, let's break up your vaccine, let's do some investigation, and for us it's easy, we might run some skin practice, etc., which becomes extremely visual for them. And sometimes they're not ready to make the decision, so always giving them an opportunity to return for discussion is really, really important. And in my head, then I'm thinking, well, future doses of vaccine needed, and sometimes we can measure antibody levels to assess level of protection, and often, of course, providing allergy testing, whether it is to the vaccine itself, or vaccine constituents, whether it is full strength or diluted, whether I need to consider intradermal testing. And so when it comes to vaccine constituents, well, egg, latex, yeast are commercially available, but sometimes for things like gelatin, neomycin, etc., we might need to prepare the reagents. So often that first consultation might not be possible, and we might bring them back. So to give you some examples of what I'm trying to kind of address today is, I'm going to go through two case presentations. So one is this child that Kylie and I recently saw in our clinic. It was an 8-week-old infant, and really here the child hadn't received any immunization. The mother had significant concern. She came into the clinic saying, I'm not an anti-vaxxer, but I had SJS syndrome after my second dose of DPT a long time ago overseas, a family from Russia, and so they really wanted their child to be tested before vaccinating. They just felt that I had some magic test that I could do. A significant fear. Really, we didn't have any details about the mother's presentation, and SJS syndrome, which is a very severe immunogenic response. It's extremely rare. Yes, can happen with DPT. So really, we in the history, it was acknowledged that yes, this can happen. Right? So I examined the child. There was really no testing. Unless we gave the child a vaccine, we wouldn't know. So we talked through the immunization schedule. I talked through what the Australian immunization schedule was. and listened to her concerns and offered a modified, slow approach. She was still quite resistant, and so after talking about the science, we actually moved on. And my job then was to make that social connection. So we talked about her childhood, how she'd grown up, about her home country, etc. And then offered her the opportunity to contact us after she'd processed all the information to return, and she did. Right? And I think as she was leaving from the hospital, was quite convinced that she would actually come back because she loved the life that she gave. And so she returned back, and really we undertook a very modified approach where we broke down all the vaccines for her and gave her a step at a time. And really, the first vaccine, she stayed in a hospital for 30 minutes. We had, contact numbers. We gave lots of support. And really, she has developed this, really nice trust in our service and prefers to come to the hospital for immunization, which we're happy to offer. And she'll just come to us every 4 weeks, and we'll just keep immunizing this child, hoping that by around 12 months of age, the child will be fully vaccinated for age. Another case that I've seen recently was a 12-month-old, and this child post-immunization had a rash. It came on 24 hours post-immunization, disappeared after 7 days. It was not urticarial, it was not macular papilla, it was more like a dermatitis. And this child really had a history of allergic reaction to egg in the past, and the whole narrative that had been established was that this was because of the child's egg allergy. Of course, she was quite concerned about the 18-month immunization, was fairly convinced the child was going to have anaphylaxis to the 18-month immunization. So really, for me, it was acknowledging the rash. I had a look at it. I explained to her. She had pictures to show, which is, again, really, really powerful. I was explained to her that it was not urticarial, didn't look allergic. It was rather immunogenic. And the child actually, by the time I saw them at around 14, 15 months of age, had really outgrown the egg allergies. So really, reassuring her about the egg allergy side of things. And so, and acknowledging the concern that she had, offered her the 18-month immunization under medical supervision, and she accepted that. Right, and that was an easy consult. Now, sometimes that may not be the way the conversation goes. So another approach often is, well, we bring them back at 18 months of age and directly do skin prick test with the MMRV vaccine. It's very visual for them. They see a negative skin prick test and then agree to move on to the vaccine given under medical supervision. And sometimes they're still resistant. We might look for antibodies to MMR, and if they are present, we would undertake a temporary exemption. And then when the child's a little bit older and is eaten egg several times and there are no concerns from that point of view, we might then administer the MMRV. So whenever I put in a temporary exemption here, because they really not clearly fulfilling all criteria of exemption, so I probably put a time limit on it. So I'd give them a temporary exemption for 6 months or 12 months, keeping the door open for them to come back for a conversation. So I think reporting adverse events is very important. Many times you feel, well, had maybe a vasovagal response and they're going to be fine. But it is really the fear that the patients have and what they've heard about that conversation that leads to them declining immunization in the future. So I think at the cold face, when you're giving a vaccine and there is an adverse event, I think it's really important to acknowledge it, to say, well, yes, exactly, this is what has happened, and let's notify and let's send you on to a specialist clinic for further discussion about it. And that way you're controlling the narrative, and also you're kind of cutting short the social story, because often these families would put it on their social media page and then it just goes out of control. So I also take the opportunity to introduce the H&E Kids Immunization Service. We are now an opportunistic immunization service available through the Children's Hospital. We work quite closely with Population Health. I'm really happy for you guys to contact us for any concerns or advice. I think Kylie is going to be present today when you're hearing my talk, and she might be able to give your contact details. But please do not hesitate to contact us or drop me an email. Thank you.